So today we're going to talk about the pituitary and thyroid, and we are studying the neuroendocrine system. And neuroendocrine system controls most of the vital organs and systems, and the neuroendocrine system connects the nervous system with the endocrine system, and that allows more precise control, and most of the hormones, they will lead to a gradual change in the systems they control, unlike the nervous system that usually makes the fast changes, and that the neuro the the pituitary and thyroid are mostly. Pituitary is the uh, place where the neuronal system connects with the endocrine system, because the hypothalamus controls the pituitary. So hypothalamus is actually the central nervous system, and pituitary is actually the hormonal system. And to better understand that, you can look at the uh, you can look at the this slide. So I'm not sure if you can see that. Um, so Hala, can you see the slide?
Yes,
Yes? Okay, good.
yes, you see.
So and this is hypothalamus, and then it sends uh, the releasing hormones. So hypothalamus will synthesize and send releasing hormones to the pituitary gland, and then uh, pituitary gland will produce tropic hormones and release them to the blood. With the blood, they go to the specific organ that specific hormone is produced in, and then in that organ the hormone will be released to the blood. That is the uh, true hormone. So there are releasing hormones that are synthesized in hypothalamus, and there are tropic hormones that are synthesized in pituitary gland, and there are true hormones that are synthesized in different organs depending on the type of the hormone. For example, adrenocorticotropic hormone, the glucocorticoids are synthesized in adrenal cortex, while thyroid hormones are synthesized in the thyroxine and 3-thyronine, that are thyroid hormones, are synthesized in thyroid. So, and then depending on the hormone, sometimes the hormones actually don't have tropic hormones. There are exceptions, like for example insulin. Insulin doesn't have a tropic hormone, but most of the hormones have tropic hormone and also releasing hormone that control the synthesis and release of these hormones from the uh, place where they're synthesized. So one moment. So and the so there are different hormones, like for example the growth hormone will promote the synthesis of the insulin-like growth factors in the liver. Then adrenocorticotropic hormone, so corticotropic, that is why it will produce, will stimulate the production of glucocorticoids and also mineralic corticoids and androgens. And then thyroid stimulating hormone will produce thyroid hormones like thyroxine and pituitary. There are two of them. Then follicular stimulating hormone will produce estrogens in females and actually also so yes, and then luteinizing hormone will produce estrogens and progestins and in females and testosterone in males. And then prolactin will actually stimulate the breast, uh, the breast growth and also the lactation in women. So these are the main hormones. There is no insulin here because insulin is controlled by the glucose level in the blood. So this is an exception. But most of the hormones have tropic hormones. Sometimes these tropic hormones called tropic hormones. Sometimes they are called just stimulating hormones. Sometimes they just called like have a specific name like growth hormone, for example, or prolactin. So it's not, they don't have name tropic hormone or stimulating hormone. So but they are actually tropic hormones, all of them. So and today we will also discuss the drugs that are used as a replacement for the hormones of the hypothalamic and pituitary, and then so this actually includes this list of the drugs, and most commonly used are corticotropin, then also human chorionic gonadotropin that is used for the infertility treatment, and then also somatotropin for the treatment of uh, the growth deficiency. So, and then hormones of the uh, posterior pituitary are most valuable is oxytocin that is used uh, for the uh, delivery stimulation in pregnant women, and then the thyroid hormones uh, are not used themselves, but the replacement therapy can be used with the levothyroxine, that is the analog of the hormone, and then antagonists are also used like like a propylthiouracil that is actually is not active as a hormone, and so or can be used in hyperthyroidic patients. Okay, so these are the overview of the hormones, and uh, um, and the first hormone that we will discuss is adrenocorticotropic hormone, and or corticotropin. Corticotropin releasing hormone is actually produced in hypothalamus, and it is responsible for the synthesis of the uh, opiomelanocortin that stimulates uh, the synthesis and release of the adrenocorticotropic hormone or corticotropin. So then, when released to the blood, adrenocorticotropic hormone goes to the adrenal gland and then stimulates the synthesis of the cortisol from cholesterol of the blood, and by stimulating the desmolase enzyme that will activate the pregnenolone and progesterone. So, and then cortisol is synthesized in adrenal cortex. So cortisol is a hormone that is released during the stress and has an anti-inflammatory action, increases gluconeogenesis, and increases protein breakdown. So all these effects are valuable on when there is the uh, the human needs to uh, be stimulated for the during the shock or the uh, during the some disease, for example, and actually that stimulates uh, uh, the gluconeogenesis, and then also increases the anti-inflammatory action. So the cortisol analogs are used as a medicines also for the same purposes, like mostly anti-inflammatory, but also uh, it, it is synthesized uh, in the adrenal gland and has the same effect as drugs. And so today the corticotropin is mostly used for diagnosis of the between the primary and secondary adrenal deficiency. So because the deficiency can be uh, because of the uh, adrenal atrophy, or can be by inadequate release of the adrenocorticotropic hormone by the pituitary. So to distinguish between these two, the patient is given the corticotropin, and then uh, if it relieves the symptoms, then the reason is the pituitary. If it's not effective, then the reason is adrenal gland. Adverse effects include uh, uh, the some toxicities like hypertension, edema, and also increased risk of infection, because corticoids are also have some uh, immunosuppressing uh, properties, especially if used in uh, large doses. And today, mostly the synthetic glucocorticoids are used, including the prednisolone and uh, uh, dexamethasone and prednisone. So then the next one is growth hormone. So growth hormone is somatotropin, and growth growth hormone is also released in the uh, by the pituitary, by the anterior pituitary, and in response to the growth hormone releasing hormone. So actually there is a releasing hormone here, and then it is released from the pituitary, and uh, secretion of the growth hormone is inhibited by the somatostatin, that is also secreted by the uh, hypothalamus, and it is released uh, more during the sleep. And with increasing age, the hormone is released, the growth hormone release is decreased, and that uh, decreases the muscle mass and then leads to the uh, elderly. So uh, the old patients become less decrease in the muscle mass, and then also somatotropin influences other biochemical reactions like bone growth, and that is why our elderly also develop osteoporosis, and then and decrease cell proliferation and growth. So and then eventually leads to the death. Uh, so there is also a synthetic human growth hormone that can be uh, can be used instead of for the replacement therapy. Uh, so the mechanism of action is based on the receptors that are somatomedins, like insulin-like growth factor 1 and 2, like EGF 1 and 2, and uh, the indications are used for the deficiency of the hormone or the failure of growth in children, and are indicated for the management of AIDS as well, like at the at, at the uh, at the some stages of the HIV, or the wasting syndrome can occur, and that can be controlled by the growth hormone, because if it's because of the deficiency of growth hormone. And then uh, it is administered subcutaneously, and the uh, uh, it requires only 1 day's dosing. Adverse effects include the pain in the site of injection, edema, myalgia, flu-like symptoms, and increased risk of diabetes because of the insulin-like growth factor stimulation. So this is a growth factor, or then there is also somatostatin, that is the growth hormone inhibiting hormone. So there are stimulating hormones like and there are also inhibiting hormones that are also released in the hypothalamus. Not all hormones have both, but like for example growth hormone have both uh, inhibiting and stimulating. Um, and somatostatin suppresses the growth hormone release, and it is uh, it is also inhibits the release of the insulin, glucagon, and gastrin. So insulin in the beta cells of the Langerhans, and glucagon is in the pancreas, and then the gastrin is in the gut. So there are synthetic analogs available like octreotide and lanirotide, and so they are synthetic analogs of somatostatin with a longer half-life, and they can be administered once every month. These drugs are used for the treatment of acromegaly, and also during some cancer, and the also used for the bleeding treatments for the octreotide. Adverse effects include the diarrhea, abdominal pain, nausea, vomiting, and also the gallbladder emptying is delayed with a long-term treatment. Then we have a gonadotropin releasing hormone, and gonadotropin releasing hormone is actually as here. Gonadotropin releasing hormone is secreted um, from the hypothalamus and is required for the releasing of the follicular stimulating hormone and luteinizing hormone. And uh, the if used for the replacement therapy, it should not be administered continuously because it should be released. It should be done in pulse manner, like uh, with like it occurs in the hub in the release from the uh, pituitary, because it's not released continuously from pituitary as well. Uh, so these agents are used in the treatment of the cancer of the prostate and also in women can be they can cause flushes and sweating. So in women it's used for the endometriosis and they are contraindicated uh, in pregnant women and breastfeeding. So the uh, adverse effects include the gynecomastia, uh, decreased libido in men and women, and also edema. So then the gonadotropins, follicular stimulating hormone, and luteinizing hormone are produced in the anterior pituitary, and they regulate the synthesis of gonadal hormones, uh, and they used in the treatment of infertility. So human menopausal gonadotropin (HMG) is obtained from the urine of the postmenopausal women and contain follicular stimulating hormone and luteinizing hormone, and also urofiltropin is obtained from the postmenopausal woman and is doesn't have the luteinizing hormone. So and then folitropin alpha and folitropin beta are human uh, mm, uh, DNA recombinant drugs and human chorionic gonadotropin is obtained from the placenta of the human uh, and is excreted in the urine of pregnant women. Uh, so actually these are all analogs of the luteinizing hormone. So they are injected intramuscularly or subcutaneously, and they are injected over the about 10 days, and then that leads to the follicle growth and maturation, and then uh, they inject the human uh, chorionic gonadotropin that promotes the ovulation in women, and then the woman becomes fertile. So then she has like several days for the uh, uh, fertilizing the egg, and then uh, actually if it's successful then she becomes pregnant. So adverse effects include the uh, of multiple births, so that actually two babies or three or five, even five at once. So then there is a prolactin, and prolactin is a peptide hormone that is secreted by the anterior pituitary, and uh, it is used for the lactation stimulation, and also it decreases the libido in women, and also decreases the reproduction. And uh, so so this actually uh, the secretion of the prolactin is uh, inhibited by the dopamine receptors, and that is why the anti-dopaminic drugs uh, can increase the secretion of the prolactin, and also hyperlactisemia that can be associated with the hypogonadism, or uh, that is treated with the uh, dopaminic receptor agonist such as bromocriptine, and they can also be used for the treatment of adenomas. So sometimes bromocriptine is also used for the treatment of diabetic patients. Adverse effects are nausea, vomiting, headache, and also some central nervous system problems sometimes. So, and then there are also hormones of posterior pituitary. So, like this, it was anterior pituitary before, and then now we are switched to the posterior pituitary, so actually back of the pituitary. And then there are two hormones synthesized here: is vasopressin and oxytocin. So oxytocin is used is important for the contraction of the uterine during the delivery, and also after the delivery, for stimulation of the prolactin, for increasing prolactin and stimulation of milk injection and lactation. So actually both of these for the maternity and for the development of the fetus and then the child. The vasopressin is actually the regulating of the reabsorption of water in the uh, 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 kidneys, and actually it's stimulating the reabsorption that leads to the increase in the blood pressure and leads to the edema. So vasopressin has chemically common with the oxytocin. That is why oxytocin is also stimulating reabsorption and leads to the increase in the height in the blood pressure and edema. So pregnant women frequently have these adverse, like the consequences of the pregnancy, like edema, high and increased blood pressure, and that is why injected oxytocin is also can increase the blood pressure. That should be taken into account when if the woman is already high in blood pressure. So the oxytocin is injected uh, for the stimulation of pregnancy. Uterine contraction can be injected vaginally or intravenously during the delivery, and for the milk injection, the oxytocin is taken intranasally as a spray. And vasopressin, or antidiuretic hormone, so it actually decreases diuresis, and is related to the oxytocin, and it acts on the receptors in kidney to increase water permeability and reabsorption in the collecting tubes. So actually there are different parts of the kidney, and actually the vasopressin acting at the end of the kidney lumen at the collecting tubes. So uh, mostly vasopressin is used for the treatment of the uh, diabetes insipidus, and it's also used for the management of the heart diseases and controlling bleeding due to esophageal varices. So the uh, toxicity includes the hyponatremia and water intoxication, and also pain, tremor, and vertigo can occur. Desmopressin is an analog of vasopressin, and it has uh, less activity at a V1 receptor that increases the blood pressure. So, and it acts longer than vasopressin and is usually used for the treatment of diabetes insipidus and also for nocturnal enuresis. So, nocturnal enuresis is actually the avoiding of pee during the night, the sleeping. Usually happens in children, but can be seen in elderly too. Uh, so desmopressin may be administered intranasally or orally. Uh, so actually the adverse effects are minor because they are analogs of uh, the natural hormone. And then there are also thyroid hormones that are synthesized in thyroid gland, and so this actually thyroid cell, and it takes up the iodine from the blood, and then iodine peroxidase makes a iod molecule from the iodine ions, and that will iodinate the tyrosine residues of the thyroglobulin, and the that will make the iodinated derivatives of the tyrosine, and then condensation leads to the formation of the hormone that can be 3-iodothyronine or tetraiodothyronine, and then they are released to the uh, blood. So two hormones are equally effective, almost equally, 3-iodothyronine and tetraiodothyronine or thyroxine. Uh, so these both hormones are important in the growth and development in children and also in adults. So there are drugs that actually uh, increase, or there are drugs that use at the deficiency that includes the levothyroxine, that is the analog of the hormone, and there are drugs that use in the uh, elevation of these hormones, and these are propylthiouracil that inhibit the iodination and also metabizole sodium, and then there are also these drugs also uh, 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 decrease the condensation also. So and the last uh, phase, the release of hormone is decreased by the iodine. So, and that is why when administered first days, the uh, potassium iodine will increase the production of the hormones first day, but further it will decrease the release of the hormone, and that is why the iodine, the potassium iodine is no more used for the treatment uh, uh, of the deficiency in the thyroid hormones. So, what can be used before the uh, operation on the thyroid hormone to decrease the thyroid hormone levels. So, I think that so during the thyroid storm actually can be used together with the beta blockers and uh, because thyroid storm will lead to the release of the adrenaline that can increase the pressure and heart rate. So to prevent that, the beta blockers can be used for the prophylaxis. So I think that is all for today, and thank you for your attention. And if you have any questions or comments, so then please feel to leave them below, and see you next week. Bye bye.
Okay, bye.